Thank you. All right, good. Well, thank you, Dr. Fuke, and this is an honor to be here to discuss the Smilow Interventional Oncology. I know this is largely the topics on research, which I have, but since a lot of people do not know what we do, in fact, my wife doesn't know what I do after 15 years, I put in some clinical slides in the front, and then we will go over some of the research programs that we have in us. So my disclosure slide. So this is our homepage, Smilow Interventional Oncology, and I have to say that we do a lot of the image-guided treatments and the procedures, therapies for patients with cancer. But I think that the hallmark or the most important thing of Smilow Interventional Oncology are our commitment and our dedication to the cancer patients and the cancer science, which I think it is quite rare even in the United States, as we are doing all of these to care for our patients in addition to image-guided therapies. But obviously, these are the sort of the main portion of our care, which are the targeted therapies, both delivering drugs as well as the the radiation, and then a lot of ablations. And there are multiple different kinds. I will mention a couple of things for targeted the cancer therapies. All of our local therapies, these are the goals, right, to be effective in killing cancer, and then organ preservation, limit the collateral damages as much as possible while we are doing this, and then the quality of life and the cost effectiveness. Now, in addition to these, there is actually a lot of a benefit from our approach where, because we have a percutaneous access to the cancer while we are doing the treatment. This is ultimate access for sequential longitudinal biopsies for tissue typing, and then it's quite convenient, right? A lot of times we can do the diagnostic biopsy as well as the treatments in the same setting, and all of these or most of these are outpatient treatments, and then they are back to work within a few days, if not the next day. Because these are outpatient ambulatory largely procedures, they are low cost, cheap compared to other therapies, and then these are repeatable as the collateral damage is minimized while we are doing this, and as I will show some of the images, and then some of the systemic effects, which we will talk about at the end. So for whether it's a primary or metastatic cancers, I mean, our treatments can be primary treatment modalities or adjuvant, as a bridging between the chemotherapy, between surgery and the chemotherapies, or as a maintenance after certain cycles of a chemotherapy or the salvage setting treatments. Largely, we started with the liver intervention, which we do a lot. However, it branched off to a lot of different organs and a lot of different cancers that we can help out, either as therapeutic treatments or palliative treatments. This is the spine met from breast cancer that we are treating percutaneously with the ablation. This is, I believe, the colorectal metastases in the liver that we are cryoing. This is a sarcoma in the gluteal area that we treated with the cryotherapy. This is a non-small cell lung cancer mets to the liver. This is colorectal mets to the lung that we are ablating. This is the melanoma mets to the adrenal gland. This is primary lung cancer, all of which we are treating targeted therapies with. So the effective tumor treatment is obviously hallmark of our treatments, but yet limiting collateral damage with the organ preservation is also equally important. It's something that we've been doing for about 20 years, radiofrequency ablation. This is what you would see in the model or the patient. This is a microwave ablation. Typically now we use this modality because it's so much quicker. Typically we can do the treatment in 5 minutes or definitely 10 minutes at the most. And these are the type of histology that you would get after the ablation. Cryotherapy, this is a freezing therapies, so it also causes effective the tissue necrosis afterwards. So typically this is what you would see on the outside, and you can see that this is a one single microwave probe going through patient's skin, and then this particular patient had a pretty bad DLCO, the 27%. We started at 3 o'clock with the scanning, and you can see where the primary lung cancer is. And then we did the prepping with the anesthesia. And then we started putting the probes in at the 352, and then we got to the probe or the lung cancer, and then we started burning. So between 355 to 405, so that's a 10-minute microwave burning, and then we are done at the 417, and the patient got extubated, and the patient went home on the same day. So this is a kind of treatments that we are delivering now for our patients, so that it goes from here to something like this. This is a model, of course, but yet you can see where and how targeted ablation can be, and then how much it's limiting the collateral damage. So efficacy, there's a tons on this. In fact, one of our the research objective is comparative effectiveness, but yet we'll just talk about a few studies. So this is a patient with the portal vein invasion from a primary liver cancer, HCC. Terrible diagnosis. Essentially, it's a death sentence in most of the places. We treated with the localized Y90 radioembolization, and you can see that the patient is clean, no tumor recurrence for 2 years. We explanted the liver with the transplant, and then the transplant explanted the liver shows no tumor, no viable tumor. There's a patient now with the another HCC, quite a difficult location, right by the bile duct, right by the portal vein, which we treated with the local drug chemo-embolization, and then you can see that this is completely treated with the CR. Just the uniqueness is that this patient was a 94-year-old female who is doing fabulously well after the treatment. So we see a lot of patients with HCC here, primary liver cancer. You can see that the newly diagnosed patients, we see about 70 to 80% of HCC in the state of Connecticut. And as you can see, roughly 50 to 60% of the new patients that we see here with the primary liver cancer, local regional therapy by us are the primary or the first line of treatment. So we treat a lot of patients. And if you look at our patients' overall survival, you can see that the transplant is at the top, which is the best treatment for these patients for liver disease as well as the liver cancer. But yet our local therapy or local regional therapy are in the middle, better than other therapies that are potentially available. So neuroendocrine tumor, often we see a lot of these patients. You can see there are tons of liver metastases from this particular patient. After Y90 radioembolization, he's pretty cleaned up. This is our paper on the cancer on this. And the metastatic melanoma, of course, a terrible disease with the large PET-avid tumor in the liver, which got treated with the Y90 radioembolization. This is our paper on this too. So this is a colorectal cancer. This is a European trial showing better PFS, adding the radiofrequency ablation with the systemic versus a systemic alone on the synchronous metastatic disease, and then also overall survival benefit of starting aggressive therapy with the ablation plus a systemic versus a systemic alone. This is the propensity score, the matched population study from NCDB, stage 1 non-small cell lung cancer, SBRT, which is the dark line, versus our local ablation. And you can see that the overall survival longitudinally is pretty much the same between the treatment modalities. This is a RCC, stage 1A, comparing total nephrectomy versus the partial nephrectomy to those of a local ablation by us. Again, these propensity score, the group comparison from a SEER Medicare study shows basically a flat line of no significant differences of overall survival in both cancer-specific survival as well as overall survival. So all of these studies that we did shows that the local therapies are not only effective at local control, but also the overall survival. Now, biopsy, of course, this is something that we do a lot. We serve a lot of patients, and yes, we get this type of adequate biopsies on every single patient, or at least we try. But I think that the one of the perhaps change or new sort of direction on biopsy is that we now understand why biopsies are important. We understand that biopsies are basis of a precision medicine in the cancer center. We know what makes it difference between the microenvironment, between the tumors, between the heterogeneity, we get this, we understand this. So our people who are doing this all are much more committed to why we are doing what we are doing versus perhaps just getting to a certain spot in the X-ray. So in a case like this, obviously there's a tumor there, but yet not all the tumors is the same, right? You have to correlate it with a PET, you have to correlate it with other studies to make sure that you get the not only accurate, but also adequate sample so that we can treat the patients fantastically well. So now we are trying to utilize optical imaging because we are very much into adequacy of the biopsy, accuracy. So these are not actually histology, these are optical imaging that we can actually do on the fresh biopsy sample, and we can even do some staining right off the bat so that we can assess the accuracy, adequacy of these biopsies much more quickly than otherwise. We are big on cancer palliation. So as chemotherapy, immunotherapies have gotten better, a lot of patients are living longer, but yet a lot of them do end up getting metastases and a lot of pains. So this is a breast cancer metastases to C2, which we are treating with the kyphoplasty or vertebroplasty. This is RCC metastases to the buttock, which we are treating with the cryotherapy, and this is sarcoma metastases, which we are sarcoma recurrence treating with the cryotherapy. This is, I believe, a thyroid cancer metastases to the hip joint, which we are treating with the ablation and the bone cementoplasty. With a lot of fluid management as well, right? A lot of paracentesis, Denver catheter, Denver shunt. Our people knows how to manage these patients and how to do this. And then the one exciting new area is that we started doing hybrid IO and ortho palliation procedures. And this patient is a breast cancer metastasis. It's a terrible disease, just involving entirely of the lower upper shaft of the tibia. Cannot walk, is completely painful. So we did all of these things that I'm going to show you percutaneously. These are K-wire placement under X-ray, and we did the coablation, and then the kyphoplasty in the same tumor, and then we did a screw placement as well as the bone cementoplasty entirely as a percutaneous procedure under X-ray, which then resulted in an outpatient treatment. Patient went home on the same day, and then within a couple of days, patient can walk now, and the pain is so much better. So a lot of these things have advanced quite a bit in advent of all of these wonderful imaging modality, which makes our job so much easier than before, and all of these will help patients getting much better treatments, much accurate treatments, as what you see here. And this is a robot picture which will eventually replace our job at some point. But this is what we have now, and this is what our people look at while we are treating our patients. So I'll talk a little bit about the research programs that we have. So there's a lot, right? So as you can see, a preclinical, translational, and the clinical program, or the research of topics, and all the ones that you see on the right-hand side, those are things that we are working on, both at the preclinical level and the translational level, and we would very much like to collaborate with everyone who are interested in these. So in a nutshell, these are the programs we have: clinical trials, typically combination trials with the systemic therapy and or the immunotherapy. We do a lot of population-based studies, a SEER Medicare, NCDB database, particularly, and the UNOS database, cost effectiveness and the comparative effectiveness. Translational studies, these are the big topics that we have. We work a lot on the novel delivery method platform, the receptor targeting, both the chemo or the drug delivery as well as the radiation delivery, biomarkers, theranostic, and the immune modulation. So we'll go over a few of the works that we've done. This is the multiple different platform. We were trying to play with what would be more effective in terms of getting to the target that we wanted it. This is one of those, the delivery method targeting SW43, which is one of the pancreatic cancer markers, and we were able to actually specifically target our drugs, tumors. This is a nano the moiety with the Chemo-Embolo therapy that we are still working quite a bit on. This is a delivery platform that combines both chemotherapy and the radiation therapy, and then delivered, and then it seeks out the receptor targets that we put in. A lot of the thermal ablations. So there's a lot of studies on immunologic or the systemic effects. This is our paper on how our therapies may potentially help the immune therapies for our patients. This is the study with the cryoablation and the CTLA-4, the drug, showing that the combination therapies works the best in terms of a tumor regression. There's a breast cancer study of a cryotherapy plus the anti-CTLA-4 shows that there's a significant increased immune response in and around the cryo site. Both the enhances T-cell activation as well as the T-cell clonality. So we are working a lot on this. This is our Y90 and the immune modulation study, and this is the current project that we have on the metastatic CRC model on the immuno-cryotherapy, and then this is also immuno-cryotherapy on the melanoma and the non-small cell lung cancer. We are working on the cancer vaccine program, the Immuno-Oncology Inside 2 injection. We have trials coming on both the non-small cell lung cancer, and we are trying to get one in the HCC, primary liver cancer, as well as our IIS. Nano knife is one of the new technologies that we brought in. This is unlike some other modality where it's not a heat, it's not a cold, it's an electrical pulse, which basically makes a bunch of nanopores on the cell membrane, and it let the cell die on its own. So it's not really like, it's not like any of the conventional the heats that we use. And those are the pictures that you can see after doing such irreversible electroporation, causing a bunch of nanopores on the cell membrane. So we just brought this in. It's under the clinical the inspection. So we'll have this program up and running soon. Now we are working on imaging, the immunoimaging, targeted imaging, to lead to the theranostics. So this is a EGFR imaging. You can see that the conventional imagings are B and C. With our collaborator in the chemistry, we develop the probes that targets and seeks two independent separate receptors at the same time, so that it can enhance the selectivity of the receptor as well as the affinity. So you can see that our picture on the right, on the A, shows highly specific with the least amount of noise, i.e. we are getting to the tumor, or in this case, EGFR receptor, much better than otherwise. And of course, the goal is a theranostic. And then this is our PD-L1 imaging, which is under investigation. And this we were working with the radiation, the tumors, and the PD-L1 expression using our imaging methods. So as you can see, we do a lot. We do a lot of supportive care for our cancer patients so that cancer patients will be better. All of you can do your wonderful work. We do also a lot of therapeutic work. And I think that the interventional oncology gives a value because it gives focus on cancer science and the cancer medicine. It gives more treatment options for our patients. We did have some of these before. However, now I think that we have a much more concerted efforts of taking care of our cancer patients through this. So why Smilow IO? Well, we have the national leadership in IO here. We actually created Society of Interventional Oncology. And now we have almost almost 600-700 members. So this is actually growing very nicely. Just like all of us, we are in a team approach, investigational approach in terms of taking care of our patients as well as our science. And we are quite committed to cancer care as well as the cancer science with everybody in this room. So we have a lot of people to thank. Virtually, we work with all of the disease groups in the cancer center. I'm sorry I didn't put in hematology because CAR T cell will cure everybody in hematology. So, but nonetheless, we obviously work with the hematological disease group as well, and a lot of our collaborators. Thank you very much.